Good. So, I promise you I'll try to be fast. I don't think no one is going to give me more time. So we're going to start to talk about obesity, cardiovascular disease. We're going to go in the surface. Okay. I remember when I was young, I read somewhere that your knowledge is proportional to your ignorance. And I want to believe that. Because after listening to Dr. Scott, my ignorance is so big that I need to think that I'm really wise. So we're going to talk a little bit about obesity, that we know that is a big deal and a big problem. Then we're going to talk a little bit about the cardiovascular disease. I want to go through 5 papers that I think they are important. They can give us some taste about the relationship between obesity and cardiovascular disease. And no more diabetes with me. I'm going to talk briefly about the relationship between obesity and cancer. Very briefly. Of course, now I cannot say it's my first time, my first conference in a boat. It's my second one. And if you think about how important obesity is, that if you go through Google, that was 3 days ago, something like that, so you get like 200 million results about obesity, cardiovascular disease, and diabetes. Of course, if you go to only obesity, it's 1 billion. In 0.39 seconds, you have all this entrance. So it means that it has to be something important, right? Obesity. And it's been for a while. So if you go to the WHO, the World Health Organization webpage, you realize that they're talking about 2016, but if you look at the number of obese people that we're going to face in probably now, it's close to 1 billion people. Meaning that that's a problem. If you look at our world in data, so if you want to go through that web, you have a lot of data, a lot of graphics, a lot of tables. I don't know how accurate it is, but it looks like pretty accurate. In this one, if you look at the obesity or overweight in 2016, you see there's pretty blue, meaning that it's very high. But think about in 1975. It was almost orange. So you don't need to understand about this thing. You see that the world. Let me do the thing. Oh, yeah. So we're in this area, right? But it's pretty orange. And it gets a little bit more orange and red in 2000. And that's what I was saying before. Probably in 10 years, it's going to be completely red. But this is in 2016, and it's pretty red. It's increasing. I choose these countries to see. But the trending is up. So we're getting to obesity in 35%. Why that's increasing? Is that increasing that much? Why are we talking about this today? Probably we're talking about the same like 10 years ago or 20 years ago. Everything is trending up. What are we doing? I don't know. The real thing is that the risk factor, it's pretty high related to the obesity. Deaths attributed to obesity in the last years always increasing, and much more in the Middle East and the MENA region. Look at how red is our area. So we're in the highest area of deaths related to obesity. So we need to do really something. This is a statement from the World Health Organization about what to do, physical activity, policies, governments. 2002, it's 21 years ago, and everything is increasing. So there's something that we're not doing properly, something that we're not doing right. Again, this is obesity classification. And again, of course, according to the BMI, we can do surgery in kind of patients. If we consider surgical-wise, the last guidelines, IFSO guidelines, the International Federation for Surgery for Obesity, now all these patients included in this classification could have surgery. We don't need to have another comorbidities because we've been working with a very restrictive policy for close to 30 years and nothing changed. So the only thing is that the obesity increased, but the indications didn't change. Thanks God that happened lately, and now we can theoretically operate on patients with obesity class 1, which was not possible before. And why this happened? Because we're talking about obesity, we're talking about many things, but why this happened? In 1950s, we didn't have such amount of obese patients. There has to be something. And this is the ideology of low fat. So in the 40s, 50s, in the States, it started to increase the cardiovascular risk, the cardiovascular diseases. And they were linking this to the lipids, to the fat, trans fat, the saturated fats. What happened? Fats are bad. We need to kill the fats, and we're going to start with a new generation of food which is plenty of sugar. So remember, this is Angel Keys. This is the guy who did a study. It's the 7-country study. I think 7 countries study. It's a study in 7 countries where he linked the deaths with high cholesterol levels. A lot of biases in this study, but everybody look at the study like the milestone. What happened? We stopped the fat. Fat was bad with the eggs, but with the fats, all these things. And then we substitute these things with the help of the food industry with the sugar, with this healthy breakfast, with all the cereals and all the orange juice and all the sweets. So from that time, I don't know if it's a causation, but it's a correlation. From that time, we started seeing an increase from 1975, increase in the obesity. This is a NOVA food classification, meaning that we have 4 types of classification of food. To me, the unprocessed foods, Scott, you are really good. I don't know how, yeah. So those are unprocessed foods. Those are probably the main foods that you should consume. And probably now are the less ones, because now we went to the ultra-processed foods. What's an ultra-processed food? Well, we have a food, we deconstruct the food, and we build it up again, but we added many things. So when you have skim milk, you remove the fat, but what do you think they put to make it milk? They put something else inside. And this is ultra-processed food. It's everything but food. Corn syrup, corn starches, so many things that we are adding to the food. And that's harming our microbiome. That's harming our genes. There has to be something in the food. And unfortunately, it's going to be very difficult to change that food. Look at that, where the whole grain bread with no high fructose corn syrup, fantastic. But you see the ingredients. In my country, in your country, in our lives, I can tell you, if you go to the bakery and they tell you, how can you make bread? Well, it's flour, yeast, water, and salt, period, right? Look at that. And it's that bread. And when our patients come to you, I have a breakfast in the morning with a sandwich. Okay, you're having a sandwich with bread that is not bread, with cheese that is not cheese, and with turkey that is whatever but turkey. But we think that we're eating healthy. This is the cereals, Kellogg's cereals, processed, a lot of sugars, carbs. And they have the stamp of the American Heart Association too, because they comply with, I don't say anything, but I say something. What can we do with obesity from a surgical perspective? Those are the surgeries that we're performing all over the world, probably with the 2 first, which are the gastric bypass, which is this one. And the sleeve gastrectomy, we cover 95% of the procedures that we do in the world. And this is another one, which is called the duodenal switch, probably the best one, but with more complications, so no many procedures are done. And why aren't we doing surgeries? Because surgery is very risky, have a lot of complications. Well, this is a paper from Ali Aminian where you can see that complications in patients with type 2 diabetes, gastric bypass, it's on the lowest. So according to these 8 procedures, it's the lowest complications rate. And if we're looking at the mortality rates, okay, it's below cholecystectomy and appendectomy, which is a pretty low risk of complications. 0, no, not at all. Everything in life has a risk. Driving a car has a risk. Don't forget that. Every time you get into your car this morning, you can die. But you never think about it, right? But we think about it with surgery. So this is a paper, meta-analysis about metabolic surgery. We're looking about different studies where we compare the weight reduction between surgery and a medical approach. And all of them, you can see with the significance that the medical treatment is not as successful as the surgical one. Look at the body weight in 5 years, diabetes remission in 5 years, or changes in the hemoglobin A1C in 5 years. You only need to look at the medical, 2 studies from Minger and Phil Schauer, and you look at the colors, and you realize that the medical treatment, the medical therapy, which is Scott, man, I'm a surgeon. I don't know how to deal with this red thing. There's a huge difference between the surgical approach and the medical approach. We're going to talk a little bit briefly about the cardiovascular disease. So there are 5 papers. We're going to go through them a little bit. And this is one important one from 2016 about epigenetic changes in diabetes and cardiovascular disease. So discovering insulin in 1921 was a milestone. Before that time, because we only knew about the type 1 diabetes, 50, half of the patients diagnosed of type 1 diabetes died in 20 months from the diagnosis. We discovered insulin. I didn't discover that insulin, of course. Discovered insulin. We started the treatment with insulin. So they started with the diabetes control complications trial. And what happened then? They said, okay, we're gonna give insulin the way we're giving insulin to the type 1 diabetes, half of the patients, and half of the others, instead of these 2 doses, we're gonna monitor and closely monitor the glucose. So we're gonna give as much insulin as we need to get the glucose levels as low as possible. What did they find? They found that the patients with more doses of insulin and lower levels of glucose were doing better. We're having less macrovascular diseases. What does it mean? It means that the hyperglycemia is probably the cause of the atherosclerosis, the endothelial cells damage, with a growing of the smooth muscle cells going to the intima, and an infiltration of macrophages and immune cells. This is a complex thing, more for medicals and surgeons, but those things, this epigenetic, this interaction with the vessels of the glucose, this inflammation, is creating this cascade of problems related to cardiovascular disease and diabetes. Epidemiology. Well, we know perfectly that when we are having this increase in our body mass, it's affecting directly or indirectly the heart function. Direct ones lower the cardiac output. There's an increase in the thickness of the left ventricle, decrease in the cavity, decrease in the ejection fraction. So the poor systolic function of our heart. An indirect one, talk about obesity with dyslipidemia, high blood pressure, the glucose and defection of the glucose levels, high glucose levels into the vessels, creating an inflammation. Of course, if we know about it, we need to talk about, and Dr. Scott spoke about that, physical activity, sleep, food environment, agricultural policies, governmental policies, many things. The third one, it's about the lipid use. It's interesting, how the heart is working. Is the heart working with glucose? No. 70% of the energy that our heart is using is coming from fatty acids. What happens with diabetes? There's damage in the mitochondria, and then we start increasing the anaerobic glycolysis. They are not burning the fats, and what's happening? The lipids are getting inside of the cells and are behaving like the fat inside of the liver. This is creating infiltration of macrophages, and is creating fibrosis. And you know the end of these things. Obesity and cardiovascular disease, the Francisco Ortega, very nice one. Nakajima in 1985, he did a study, and he took these patients with obesity, and he saw those patients with less than 15 years of obesity and those with more than 15 years of obesity. What happened? They realized, it looks stupid, but it's true, the ones with less years of obesity, they had less cardiovascular disease than the longer ones. Okay, so then Abdullah, following the Framingham study, he realized that the longer you're obese, you increase the risk of cardiovascular diseases. Every 2 years, you increase 7% the risk of developing cardiovascular disease. What does it mean? The higher BMI and the higher duration increase the mortality. And one point is good, fat but fit. We all know people that they're suffering from obesity, but they're metabolically fit. And that's very important. Why? Because you can be obese. Of course, somebody, they want to lose weight because they want to become a model or something like that, an athlete. But we can do things with our patients suffering from obesity, because if they are fit, if they are cardiorespiratory fit, the risk of cardiovascular disease are much lower than, of course, that obese and fit and lean and fit. This is the graph. The dots, the black dots, are the fit patients, and the triangles, they're unfit people. You see, like an obese patient but fit has much less cardiovascular risk, much less, than a lean patient but is unfit. Meaning that sometimes with insufficient weight loss in bariatric surgery, we don't lose that much. We think that we fail. Even with a loss, we can have a lot of benefits from that. And the last one is Dr. Fuster, distribution of the fat. The distribution of the fat, we know that 80% of our fat is subcutaneous fat and 20% is visceral. Here, there's a lot of genetics, it's true. When we are getting weight, our body knows where the fat is going to be stored. And the fat is going to be stored, if it's visceral, is going to be a higher risk of cardiovascular disease in the liver, in the pancreas, in the heart, inside of the abdomen, not in the subcutaneous one, and not in the belly. And what happens? So there's a move from a healthy fat to unhealthy fat. This unhealthy fat, this growing, is creating adipokines, is creating interleukins, that is creating a pro-inflammatory ones, much more than the anti-inflammatory adipokines that the good fat is producing. Everything is going to result in the same, with a myocardial infarction, vascular disease, stroke, all of them in cardiovascular disease. Well, again, this paper about comparing medical treatment and surgical treatment, cardiovascular drugs, much less when we are dealing with surgery than medical approach. Cardiovascular risk, much lower when we're performing a room-wide or bilipancreatic diversion than when we are treating the patients with medical treatment. Lifestyle intervention, medical management, we're going to use the same. You don't need to know the graphs. The yellow one is the surgical cohort. The blue ones are the medical and lifestyle management. No matter you're talking about hemoglobin A1C, systolic, weight loss, cholesterol. Another paper, if you look at the medications that we're taking, patients taking antihypertensive medications, you don't need to know a lot. You see here that the two columns here, before and after, this is the medical arm, baseline and 12 months, they are pretty similar. There are no changes. Here you see the one on the left, it's one, and in the right changed a lot, meaning that you decrease the amount of medications that the patients are taking after doing bariatric surgery. What about cardiovascular disease after and heart failure, congestive heart failure, control and room-wide gastric bypass? Much better. What's the effect of obesity in the cardiovascular events? If you're lean, you have a less risk. If you're suffering from severe obesity, you're having a higher risk. No matter if we are talking about heart failure, coronary disease, or stroke, which are the MACE, the major adverse cardiovascular events. If we look at the odds ratio, the risk factor regarding myocardial infarction, if you look at smoking, it's 2.8. Well, that's high. If you have diabetes, it's 2.3. If hypertension is 1.9.
5 minutes, Dr. Abril.
Perfect. If you have the three of them, it's 13. But if you add obesity, which is only 1.6, it becomes 21 when you add smoking, diabetes, and hypertension. And if you look at your patients, most of the times when you're suffering from obesity, it's very frequent having diabetes, having smoking, and having hypertension. This is, again, what's the mortality and morbidity in men, a cardiovascular risk, if you are normal, if you're lean, or you're overweight. It's a huge difference. In female, it's less, but it's the same. This is the Cleveland Clinic Metabolic Surgery Cohort from Dr. Ali Aminian. So it's more than 2,000 patients that had bariatric surgery since 1998 till 2017. And we matched with propensity match score with these patients with a control and medical treatment of diabetic patients. The surgeries that we perform, most of the times, 95% of the times, is bypass and sleeve gastrectomy. Gastric band is something that is not done anymore, but it was included in the study, and duodenal switch. The results. Again, you see the control is the blue one, you see the surgical one, the metabolic surgical one, it's the orange or the yellow one. If you're looking at the primary composite, which is MACE-6, where we're looking at coronary artery events, nephropathy, strokes, heart failure, atrial fibrillation, and all-cause mortality. And the secondary composite is the MACE-3, which is the typical one about a stroke, myocardial infarction, and all-cause mortality. Always decrease in the surgical arm. If you look at, again, the trend of the weight loss and the hemoglobin A1C comparing the medical arm and the surgical one, there's a huge difference, significant difference between the non-surgical controls and the metabolic surgery ones. And to finish these 3 minutes that I have left is the relationship between cancer, obesity, and cancer. Probably everything is the same and is causing the same things. The only thing is that now we are more aware, because cancer takes longer to happen, that we're more aware that, okay, patients with obesity, the number of cancers are increasing, and that's related to the type 1 pro-inflammatory cytokines like interleukin-6, TNF-alpha, interferon gamma. Those are creating an inflammatory environment with dendritic cells, T cells, macrophages, that probably are creating a mitochondrial, the one with the Krebs cycle that we all study and we never know about it. The mitochondria probably is the key of everything. So we have 13 cancers associated with obesity. That's proof. It's not something that we're making up. This is real. This is 13 ones. And if we look at the splendid study where Dr. Croix included, Dr. Ali Aminian as well, they tried to see the association between bariatric surgery, how bariatric surgery affected the risk of developing cancer. This is the surgeries that were performed, weight loss, hemoglobin A1C, and then you can see here that the more you lose, the less chances for suffering cancer in the future. You can see the same approach, medical versus surgical, lower risk of developing cancer in the patients in the surgical arm. So the survival benefit after bariatric surgery is well known, more than 29 studies. If we look at this cohort for more than 174,000 patients, we know that there's benefits coming from bariatric surgery. So that's probably the summary of this last study, where near 50% has a lower risk after surgery compared to the usual care, and that's something. That's something. And think about the number needed to treat. Only for prevent one death, a patient with diabetes in 10 years, we need to treat only 8 patients, meaning that it's worth it to do that. Look at the benefits that bariatric surgery has in all our patients related obesity, related diabetes, and related cardiovascular disease. So obesity is a serious epidemic, no doubt. Type 2 diabetes is related to obesity in 90% of the cases. Cardiovascular disease is the first cause mortality. Of course, cancer is linked to obesity. The best current treatment for all of them is metabolic surgery. We can discuss about that, of course. And the sooner we treat obesity, and I'm talking about only surgery, medical approach, the sooner we treat obesity and its comorbidities, is the best for our patients. Again, this is the same building, the same hospital, and we're welcome to come. A little bit more than 5 minutes, but that's it.